Good morning to all of you. I warmly welcome everyone for today's CPD program organized by Government Medical Officers Association and Society for Health Research and Innovation. The webinar link will be open to you until 10 a.m. and no late attendees will be entertained thereafter. You will be given CPD points which are strictly adhered to in CPD guidelines. Apart from CPD points, you will be given an e-certificate for participation. Each attendee should attend till the end of webinar to obtain the e-certificate, and the link for applying e-certificate will be sent to the chat box at the end of session. Also, we kindly ask you to mute your microphones and switch off videos to avoid any interruption during the session. So let me invite Dr. Himal Osunda Kalambarachi, Acting Consultant Physician, to introduce today's speaker. Over to you, sir.
Good morning, everyone. Thank you, Dr. Maliti. Thank you, everyone, for joining this wonderful morning on a discuss another very important topic you encounter day-to-day practice on coronary artery disease. So let me remind you first, this is another collaborative sessions which we conduct in our session with Sri Lankan College of Internal Medicine and GMO Sri. So today our speaker is Dr. George Rajeevan Francis, who is a senior lecturer in Medicine, Faculty of Health Sciences, and as well as honorary concerned cardiologist in Teaching Hospital, Jaffna, Dr. Rajeevan Francis is a product of Faculty of Medicine, University of Jaffna, where he obtained his MBBS at 2006 and he obtained his MD Medicine University of Colombo 2015. He completed his fellowship in cardiology and cardiac imaging at Papworth Hospital in United Kingdom. Currently, he is serving as a senior lecturer in medicine, Faculty of Health Science in Eastern University of Sri Lanka. And he is honorary concerned cardiologist at Teaching Hospital, Badiklo. So, without further ado, I would like to invite Dr. Rajeevan Francis to start his talk. Dr. Francis.
Yes, thank you, Himal, for that kind introduction. So let us start. Okay, I hope I'm visible.
It's clear, it's clear. We'll continue.
Right, fine. Okay, so good morning, everyone. So we are going to talk about an important topic and a common topic that many of us encounter in our practice, as well as many people encounter in their daily lives as well. So coronary artery disease has become endemic to our country. I'm sure each and every one of you knows someone or is close to someone who has had coronary artery disease at some time in their life. So what I'm going to do is I'm going to talk a little bit about the pathophysiology of this condition. We are going to try to understand what coronary artery disease is, and we'll see if we can work out what type of management will be ideal for different types of presentations. So, yeah. So cardiovascular disease, it is the world's #1 killer. If you look at the statistics, almost 18.6 million people are dying of cardiovascular disease each year. That is 33% of the global deaths. Now, of these cardiovascular deaths, majority are due to this coronary artery disease. So you can see the other major causes for global death have been put on the side. You can see that cardiovascular death stands out higher than all the other causes. Now, into this cardiovascular disease, both heart attacks as well as strokes fall into. The underlying pathophysiology in a way is same for both these diseases. So let us try to understand a little bit about this pathophysiology with specific emphasis on this coronary artery disease. So let's go back. In Sri Lanka, we know that currently this cardiovascular disease is a very big problem. Daily we see patients admitted. Daily we hear about people being admitted, people dying. due to heart attacks, coronary artery disease. And many people above the age of 40, they themselves are worried. Am I at risk? Is there a chance that I can get coronary artery disease? Is there a chance that I may get a heart attack? So this fear is there not only among the general population, it is there among our healthcare professionals as well, among doctors, MOs, consultants, nursing officers. Everyone have this fear in our country because it is so common and so prevalent. So let us go back a little. When you understand something, why am I concentrating on the understanding? Is because understanding is much deeper than knowledge. I'm not going to go into the guidelines and management principles and things, because I'm sure many of you would have had many talks, or you would have had many sessions where you get knowledge. But I want to try to make you go into an understanding of what this coronary artery disease is. Now, coronary artery disease isn't something new. In the time of the Egyptian pharaohs, a princess has died at the age of 40. So let's go to a bit of a historical aspect. She died at the age of 40 years. Then almost 1,500, 2,000 years later, or 3,000 years later, this researcher, Gregory Thomas, he and his team decided to do a CT scan on this mummy. It was just a study. They were not searching for anything particular. They just did a CT scan. And they actually found the cause of death. It was coronary artery disease. So this young princess at the age of 40 years, almost more than 3,000 years ago, has died of coronary artery disease. When we look at this picture of this CT, we get immediately reminded of the disease prevalence that we see now in our setup, in our country. So this is not a new disease. It is not something that has suddenly come up. It has been there. It has been there for a long time. However, our understanding of this disease has increased many folds over the last centuries. So we have now understood a lot regarding this disease. We have understood a lot about how we can prevent this disease and how we can treat this disease. So if you think of coronary artery disease, what is this coronary artery disease? It is a disease where the coronary arteries, that are small arteries which supply the blood to the heart, they are occluded due to a process of this atherosclerosis. Now, there are different types of myocardial infarction where you have vessels with non-occlusive myocardial infarction and things. But the majority of this ischemic heart disease, the majority of coronary artery disease that we talk about, that we see, is due to this atherosclerosis. So when you talk about understanding coronary artery disease, it's important that we first understand what this atherosclerosis is. So understanding of coronary artery disease is understanding of this atherosclerosis. So what is this atherosclerosis? This is a very famous picture. I'm sure almost all of us during our third year medical student period, we would have seen this picture in our Robbins or in our pathology books. So very, very common picture. But it tells us a lot. It tells us what this plaque is, what this atheromatous plaque is. You can see on the bottom, this is the media of the blood vessel. Then you have a necrotic core. A necrotic core is an area that is filled with this fatty material. And importantly, I want you to note macrophages and foam cells and lymphocytes, which are inflammatory cells. So this necrotic core it does not have only fat. It's not just some fatty material. It's a fatty material with inflammatory cells. Then this is covered by this fibrous cap. The fibrous cap can vary in thickness. We'll see a little bit about that later on. So this fibrous cap is a dynamic thing. The necrotic core is also dynamic. So we will see a little bit more about that as we go on. Now, where do these plaque usually develop? We have different layers in our arteries. It is usually subendothelial. So within the subendothelial layer, that is where this atheromatous plaque is going to develop within the coronary vessels. Now, if you look at the pathophysiology of how this atheromatous plaques develops, over the time there were many theories. But currently, the theory that is accepted is that a theory that we term as response to injury theory. Response to injury theory. So whenever our body has an injury, then automatically the next step is going to be inflammation. So the response to injury is going to be inflammation in our body. So that is our normal protective mechanism. Now, unfortunately, when you have this long-term inflammation going on at the level of the coronary vessels, there can be some interaction between cells involving the immune system, the smooth muscles, and the fibrous tissues, and that leads to the formation of this atheromatous plaque. I'm not going to go into the finer details. I just want you all to understand that this atheromatous process is an inflammatory process. So another way of explaining this, same thing, you have some risk factors. We have some risk factors for atherosclerosis, which many of us are aware of. This leads to endothelial injury. The injury is at the endothelial level. When this injury occurs, as when any injury occurs anywhere, there is going to be an inflammatory process where you have these macrophages infiltrating. Now, on top of that, we are going to get this lipid insinuation into this plaque as well, which forms these foam cells, which are actually macrophages with lipids. Macrophages with these lipid particles. Most precisely, it's going to be these LDL particles have been engulfed by the macrophages, and they form these foam cells. Now, this is an inflammatory. These cells are more prone to inflammation, and they will cause T cell infiltration. So you have macrophages infiltrating, and then you have the T cell infiltration. When T cell infiltration happens, then you are going to get the other changes of this fibrous tissue, platelet addition, and things. So this atherosclerosis will later on lead to two possibilities. One, it can weaken the vessel wall. If it is within the vessel wall, like in the aorta or in a cerebrovascular vessel, it can weaken the vessel and then cause an aneurysm to develop, or it can go into dissection. The other possibility is it can over time cause stenosis of the vessel. Now, this stenosis, it can be a slowly progressive stenosis, where the stenosis over time, it becomes more and more and more, and subsequently occludes the blood vessel. Or it may be something that happens very rapidly. That is known as this plaque rupture or plaque erosion can happen, and suddenly a thrombus can also form and cause this acute occlusion. So this response to injury. Now we can see how these risk factors are playing into the ultimate manifestation of the disease. So many people, they struggle to understand, especially our patients, when you try to explain that you should be more physically active, you should stop smoking. Then many people, they try to ask, why is that? So unless as health professionals, if we can explain to them, this is why we are telling you to stop smoking. This is why we are telling you to control your diabetes. This is why we are telling you to control your hypertension, that you need to control your hypertension. You need to follow up the clinic properly. If we can explain those things to the patient, then automatically the patient's compliance will be better, and the outcome for that patient is going to be better, which is going to be our ultimate goal. So remember this, risk factors lead to endothelial injury, which causes inflammation, and this atheromatous or atherosclerosis itself is an inflammatory process. So these inflammatory cells are involved in the pathogenesis. Now, what are these risk factors? There are a lot of risk factors. So traditionally, we tend to classify these risk factors into two: modifiable risk factors and non-modifiable risk factors. So when you say non-modifiable risk factors, they are something which we cannot really do anything to control them. For example, if I have a family history, if I have a family history of ischemic heart disease, then it's in my genes. I cannot change my genes. So at the moment, so there are studies and there are studies going on where they are trying to localize the genes and get gene therapy and things. But at the moment, in our current scientific knowledge, we cannot change our genes. So that is an unmodifiable risk factor. As we grow older, we are at more risk of developing this atherosclerosis. So age, that is another thing that we cannot do anything about. Gender, males are more prone to get this atherosclerosis than females until menopause. After menopause, the risk equalizes. So gender is also something that we cannot do anything about. Menopause is also something that we cannot do anything about. So these are what we call as non-modifiable risk factors or unmodifiable risk factors. Then on the other hand, we have these modifiable risk factors, something which we can control, something which we can do something about. Of those, smoking is one of the most important things. Smoking, just quitting smoking, stopping smoking, reduces the risk of atherosclerosis manifold. Lack of exercise, that is something that is endemic in our country. When you go to Western countries, European countries, you can see that the people are very active. They want to exercise. But unfortunately, in our setup, maybe it's due to our climate, we don't like to sweat. We don't like to, if we are sweaty, then we feel very uncomfortable. We don't like that. So therefore, we tend to limit our activities. We like to stay in AC rooms and we do not want to exert ourselves. So this lack of exercise, that is another important risk factor. Then we have diabetes, hypertension, dyslipidemia, which are disease conditions which can be treated appropriately. And thereby we can reduce the risk of these things. In addition to that, we have a lot of non-traditional risk factors. I'm not going to go into those at the moment. There is a nice article in e-medicine with this picture and this thing, so you can just read about it later on if you want to look at these non-traditional risk factors. Now, most of the patients with myocardial infarction, with ischemic heart disease, they will have all of these traditional or one or two of these traditional risk factors, these conventional risk factors. So these risk factors are well described, and most of the myocardial infarction, so most of the ischemic heart disease patients will have one or two of these risk factors. There are a small percentage of patients whom we do not have all of these traditional risk factors. For them, we have to look whether they have any of these non-traditional risk factors. But it's a rare entity. And when you take treatment of the masses, it's not really that important that we go into these minor risk factors for everybody, because most of the patients will have these well-defined risk factors. Right. Now, when you talk about this atherosclerosis, the first it leads to this, what we call as fatty streak. So the first thing that we saw, this risk factors they are doing, they are causing endothelial dysfunction. They are causing endothelial injury. So this endothelial injury will lead to endothelial dysfunction. So then there is a function for the endothelial cells which is lost. Then when this endothelial dysfunction happens, the next step is these LDL particles in the blood will go within the intima. So in a patient who has higher levels of LDL, then more LDL is going to go into that plaque. If the LDL levels are lower, then less amount will go in. So that is the importance of controlling the LDL in the blood. So when the LDL goes in, macrophages also go in at the same time due to this inflammatory process. And you have this formation of foam cells. Foam cells are macrophages with LDL particles. And then you have this foam cell accumulation. That is what is known as this fatty streak. So these foam cells. So you can have a look. So these risk factors, they are going to lead to these steps. Now, when we said endothelial cells, they have some functions. So what are these functions? These atheroprotective functions. Number one is they secrete nitrous oxide. So nitrous oxide is becoming more and more famous, let's say, for many diseases and many conditions. People talk a lot about nitrous oxide nowadays. Now, nitric oxide has an anti-atherosclerotic substance. It is an atherosclerotic substance. It causes vasodilation and also inhibits this platelet aggregation and stops inflammation. So all the functions, all the factors that cause this atherosclerosis plaque to develop can be prevented by increased endothelial nitrous oxide. Now, the risk factors that we talked about, this diabetes, hypertension, they all inhibit the secretion of nitrous oxide. So studies have found that these nitric oxide levels are reduced in patients with these risk factors. Also, these endothelial cells, they secrete another enzyme. So this enzyme, it acts as an anti-atheromatous role. It removes the oxygen species. It prevents these free radicals from damaging the blood vessels. So therefore, it reduces the inflammation at the site. So when you have these more and more risk factors in the blood, it's going to cause this endothelial functions are going to get disturbed, and you're going to get this endothelial dysfunction happening. And then we have this LDL, which crosses the endothelium into the intima. Now, this process of crossing into the intima is made easier when you have this endothelial dysfunction, because the endothelium normally protects or is a barrier for this LDL to cross. But when this endothelial dysfunction happens, it promotes this LDL deposition. So all of these things like hypertension, they are going to cause stress on the wall. When you have a high blood pressure, just think of a tube. When you have a high pressure within the tube, it's going to be stretched. It's going to be under pressure. It's going to be sort of pulled out. So there is going to be shear forces. We call those as shear forces. Those will promote this inflammation. And then the foam cells enter. So we have these stages of atherosclerosis, from the healthy vessel up to this complicated plaque. So the first stage that we see is this fatty streak. Then we have this fibrofatty plaque, then the complicated plaque. So this is a pathological view of what this fatty streak is. It is the first gross pathological change that we can see of a plaque. The first gross pathological change of a plaque, which we can see visually. It's not something that is microscopic. It is something where we can see visually. Now, here is an interesting thing. When does this plaque begin to form? When does this fatty streak actually begin? So if you look at this natural history, when we are born, at birth, our vessels are normal. But from the time that we are born, or sometimes even in utero, we are being exposed to these risk factors. And by the time child is 10 to 20 years, within adolescence, the fatty streak is seen. So fatty streak, it starts at childhood, basically. This fatty streak then thereafter progresses. So we are exposed to more and more risk factors over time, more and more risk factors. Ultimately, we develop the plaque and we start to develop the clinical manifestations later on in life. So if we want to, it is very difficult for us to avoid exposure to risk factors. We are going to be exposed to all of these risk factors. Even aging is a risk factor. We cannot avoid aging. So we are going to be exposed to risk factors. Our patients are going to be exposed to risk factors. But by reducing the exposure to risk factors, we can prolong this. Say the fatty streak, it comes at the age of 10 to 20 years. We can make it go a little longer. We can make the fatty streak come maybe at the age of 30, 40 years. Then thereafter, you can we want to prevent these complications happening at an earlier life. So later on, this fatty streak will develop into this fibrofatty plaque, where you have this fatty material, which is this necrotic core, covered by a fibrous cap. Now you have this necrotic core. As I said, the necrotic core has some lipids, foam cells, smooth cell, muscle cells, and inflammatory cells. Then you have this fibrous cap. Now the fibrous cap, it is as mainly this collagen and smooth muscle cells. The clinical manifestations of atherosclerosis, the clinical manifestations that we see, that is our myocardial infarction or coronary artery, this is ischemic heart disease itself. It depends a lot on this fibrous cap. Now, if the fibrous cap is thin, then these plaques are more prone to rupture and ulcerate and cause acute problems. But if you have a thick cap, then usually they are more asymptomatic and will present later on in life with more stable anginal symptoms. So this is the importance of this fibrous cap. We cannot prevent exposure to risk factors. Therefore, we cannot prevent the formation of this atherosclerotic plaque, but we can delay the formation by reducing the risk factors. Also, it will be nice if we can make this fibrous cap thicker. Then we won't have these acute presentations which we are really more worried about. So we can classify the plaques into two types. One we call as a vulnerable plaque, and the other we call as a stable plaque. So you can see the difference. So the important difference is the thickness of the fibrous cap and the content of the lipid core. When you have a larger lipid core, you have a thin fibrous cap. When you have a smaller lipid core, you have a thick cap. Thick cap is better. The patient or the person is going to present with stable anginal symptoms, which we can manage quite well. It is the acute presentations which we are all more worried about. So this vulnerable plaque. So this vulnerable plaque, it can go to rupture, or it can cause this acute manifestation, lead to a myocardial infarction. Whereas the stable plaque does not really cause that much. Even if the patient has had a vulnerable plaque which underwent plaque rupture, then we can make the patient go into this stable phase. So let's see how. So we have the spectrum of coronary artery disease. We have stable angina, and then we have unstable angina, non-STEMI, and STEMI. Now look at these pictures. What do we see here? We see this in the first picture where you see stable angina, you see an atheromatous plaque, a very large atheromatous plaque with a small lumen for blood to flow, but that's all. Here in a non-STEMI, you can see there is this atheromatous plaque with a thin fibrous cap and a thrombus. A thrombus has also developed, but there is still space for blood to flow. But in a STEMI, it has almost fully occluded the blood vessel. There is no space for blood to flow. So it's all a complete or almost complete occlusion of the coronary blood vessel. So this spectrum, stable plaques and vulnerable plaques. So stable plaques, they usually lead to chronic coronary artery disease, whereas vulnerable plaques, they lead to this acute coronary syndrome. So chronic coronary disease, that is what we know as stable angina. Acute coronary syndrome, they are our presentations of unstable angina, non-STEMI, and STEMI. So just to summarize the features, you have stable angina and you have acute coronary syndrome. You can see here the pathophysiology is a fixed stenosis and stable fibrous plaque. Here you have a dynamic stenosis. Why is the stenosis dynamic? It is because there is a thrombus as well, and you have a ruptured and inflamed plaque. Now, just by looking at these two pictures, you can appreciate the management is going to differ. When you have stable angina, you have to manage an atheromatous plaque only. Whereas when you are managing an acute coronary syndrome, you have to manage a broken atherosclerotic plaque as well as a thrombus. You have to manage the thrombus as well. So let's look a little bit more about this vulnerable plaque. Now, this vulnerable plaque, as we said, it has a thin fibrous cap and it has a large lipid core. And it has a lot of these inflammatory cells within. Now, we saw this atherosclerosis itself is an inflammatory process. As the inflammatory process keeps on going, keeps on increasing, it keeps on recruiting more and more and more and more LDL into the into those macrophages and creates a larger lipid core. So when you have a larger lipid core, the fibrous cap gets stretched out and it becomes thin. But if you have a smaller lipid core, then the fibrous cap will contract and become thick. So we want to stop this inflammatory process. We want to reduce or slow down this inflammatory process, which is making the plaque larger. Another important thing of inflammation is whenever you have inflammation happening, then it also recruits through various factors or components, neovascularization. New blood vessels tend to form within the atheromatous plaque. Now, this is a very dangerous condition. When you have new small blood vessels forming within an atheromatous plaque, these blood vessels are very thin. They are very friable. They can rupture very easily. They can break very easily. And you can imagine what will happen if you have a blood vessel breaking within a plaque. That's definitely going to cause plaque rupture. The pressure within the plaque is going to suddenly increase. The plaque is going to break. And the moment the plaque breaks, usually it breaks at these corners, corners where you have this thing. It then prothrombogenic material is being exposed to the blood and a thrombus will form at that point. So this vulnerable plaque, large lipid core, inflammatory cells, neovascularization, things that we want to prevent. Now, this is a picture of what we call as OCT, optical coherence tomography of a blood vessel. So I just put this up for you to see within a coronary vessel. This is a plaque has ruptured here. And this is something that we call plaque erosion. Now, we are familiar, or many people are familiar with this concept of plaque rupture. But plaque erosion also can cause this myocardial infarctions. The plaque gets eroded. So if we have a thick fibrous cap, then the risk of both of these is less. Right. So now let's try to see if we can put what we saw so far into the practical management of the patient. So how can we understand? So for us, as medical professionals, when you think about pharmacological management, there are many medications where we consider or where we have to think about when we are managing patients with ischemic heart disease or coronary artery disease. Now, these are common medications which everyone are very familiar with. Aspirin, clopidogrel, statins, nitrates, ACE inhibitors, beta blockers, fibrinolytics. We have coronary intervention and we have heparin. So these are medications which are the mainstay of managing coronary artery disease. Even though there are a lot of other medications, there are a lot of other things, but these medications and intervention are the mainstay of managing all patients with this coronary artery disease. And most of you at some time would have definitely prescribed one or two or all of these medications and procedures. Definitely. Right. So let's see our understanding. So let's first come to an acute coronary syndrome. So let's take an example. We have, say, a 45-year-old male who is presenting with a sudden onset of chest pain, central chest pain. He's sweating. He's saying the pain is radiating down his left arm and he's nauseous as well. So that presentation, immediately all of us will definitely think this patient is having an acute coronary syndrome. Right. So moment that thought crosses our mind, acute coronary syndrome, then the next thing that we think about or should cross our mind is this patient within his coronary vessel, he has had an unstable plaque or vulnerable plaque, which has either ruptured or ulcerated, And now we are having a thrombus as well as a ruptured plaque within his coronary vessel. So I have to manage these two things. Both of these have to be managed. So how are you going to manage? How are you going to manage thrombus? How are we going to manage his unstable plaque? Right. So when you talk about thrombus, then automatically we think about these antiplatelets and coagulation cascade and things. So yes, aspirin. So any patient who comes with an acute coronary syndrome, those of you working in the medical wards and emergency settings, you all know the first thing that we give is we are going to load the patient with aspirin and clopidogrel. These are both antiplatelets. They are going to work against this thrombus. They are going to stop the thrombus from becoming any larger. And then thereafter allow the body to break the thrombus out. Fibrinolytics. We have streptokinase, which we used previously. Then currently we have tenecteplase. So these medications are fibrinolytics. They will break down the thrombus. They are going to work to break down this thrombus. So these two together should be enough for us to remove the thrombus. Then you see most patients, or all patients actually with acute coronary syndromes, we treat them with heparin. So usually nowadays in the form of enoxaparin or low molecular weight heparin. So low molecular weight heparin, most, even though it's not correct to mention in such a way, but we are all familiar with the word, with the name enoxaparin, which is the trade name. So enoxaparin is a low molecular weight heparin. Now this enoxaparin, we are going to give for a certain number of days following this acute coronary syndrome. So how many days are we going to give? Why are we giving this enoxaparin? So we can work out, okay, we're giving aspirin and clopidogrel to remove the thrombus, as an antiplatelet. We are giving fibrinolytics to break the thrombus. Then why are we giving this heparin? Now you have to think of the plaque. The plaque is like a raw wound. It's a ruptured plaque or ulcerated plaque. It's like a raw wound. So just imagine we get a wound in our hand. How many days is it going to take for us that wound to heal? It's going to take around 3 to 5 days. What will happen at that point? A thrombus will form. Say we remove the thrombus off. What will happen again? At that point, again a thrombus will form. You remove the thrombus, again a thrombus will form. So if that happens within the blood vessel, so we are giving aspirin, clopidogrel, we are giving the fibrinolytics, and we are removing the thrombus. But the effect of, say, tenecteplase, its half-life is very short. Within a few hours, the effect of tenecteplase will be gone. Then again a thrombus might form on that wound, that ruptured plaque. So therefore, to prevent that thrombus from forming again for the next few days, until that wound heals, until the epithelialization happens, we want to continue heparin. We want to keep the patient on heparin. So that's why we usually keep the patients on enoxaparin for the first few days of an acute coronary syndrome. There is no point of giving heparin for longer. Say for some reason you could not give heparin at the initial stages. Patient got some bleeding manifestation or something. We have stopped. But there are instances where I see where we have seen patients being treated with heparin even after that, because saying we have to complete this number of doses, 6 doses, 8 doses, 10 doses. There is no doses as such. It is the time. It is the time from that acute coronary syndrome. We have to give enough time for the wound to heal, for epithelialization to happen. Once that happens, there is no need to continue this heparin. Right. Then we have this unstable plaque. This is it's like a broken volcano. This fatty material is keeping on coming out and out and out and out. We want to stabilize the plaque. We want to make it contract. We want to make it shrink. So here, the best medication that we have currently are these statins. Of that, atorvastatin is the one that we use. So atorvastatin is given when the patient comes in immediately, because we want to stabilize that plaque as soon as possible. We want to make that plaque contract. We want to harden the plaque. If the plaque is a soft plaque, it's going to keep on extruding that material and the thrombus will continue to form. So this is the main management of an acute coronary syndrome when you talk medically. Now, Coronary intervention. When you talk about acute coronary syndromes, coronary intervention is the best type of management that we can offer, because we are able to tackle both the thrombus as well as this plaque. So mechanically, we will break the thrombus and remove the thrombus. We give some other medications also to break down the microthrombi. And we can then stabilize the plaque by placing a stent. So acute management, coronary intervention in acute coronary syndromes is usually having a better outcome. So of course, we have to assess the risk and benefits. So patients at more risk of death. So we have the spectrum of unstable angina, non-STEMI, and STEMI. So patients with a STEMI, they are at a higher risk. They are at the highest risk of death. So they have the best benefit from coronary intervention. The others, non-STEMI and unstable angina, we have to risk stratify the patients. If we think the risk is high in an unstable angina patient, non-STEMI patient, there are various scores like TIMI score, Gray score. There are scores which we use. If the score is high, then those patients, again, they will benefit by coronary intervention. Coronary intervention in acute coronary syndrome is a very, very effective way of management. Now, when you come to chronic coronary syndrome, or this what we commonly known as stable angina, we have this stable plaque. So here we don't have to consider thrombus that much. We are not considering, but the patient comes with pain. So here typically we are going to get a history of a patient, say a little elderly patient, 65, 70 years. He is coming with exertional angina. So when you ask him, he says, I've had this symptom for the last 2 or 3 years. Whenever I walk this particular distance, if I go up to this particular bus stand, when I walk up to this particular shop, I get this chest pain. Then I stop and wait for some time. The pain will go away. Then again, I can walk. When I walk this particular distance, again, I will get the pain. I will stop. So that is stable angina. Here, the patient is having anginal symptoms, but they are stable. So here, it's important that we give anti-anginal therapy. The first line anti-anginal therapy is a beta blocker. Angina is due to inadequate oxygen supply to the myocardium, supply and demand. So this plaque is a thick plaque. We are not going to be able to do much to increase the supply of blood. But we can reduce oxygen demand to the cells. We can reduce the oxygen demand to the myocardium. So these beta blockers are the first line. Calcium channel blockers can also be used if beta blockers are contraindicated. Then thereafter nitrates. Nitrates will help to dilate some small blood vessels. They will help in the collateral flows. They will, this fixed stenosis, it's not going to do anything. But by causing a small dilatation in the blood vessels, it can increase the blood flow to the myocardium. Also, it causes venodilatation and reduces the preload to the heart, and thereby reducing the workload to the heart. So that is how the nitrates are going to work. Then you have a whole lot of other medications which also work through various mechanisms as anti-anginal therapies. So you all can read about these medications and their mechanism of actions. But you will all note that everything is actually not doing anything to the plaque. It's not doing anything to the necrotic core or to the fibrous cap. All of them act in a way to reduce the symptoms of the patient, because that is the most important thing affecting the patient now. Now, these patients, they have this plaque, unfortunately. So therefore, they are, even though at less risk, but they still are at risk of developing plaque rupture, and they have this atherosclerotic disease. So even though there may be a particular plaque which is causing these stable anginal symptoms, because he's having this atherosclerotic disease, he may have another plaque further down or somewhere, which is an unstable plaque, which might rupture. So therefore, secondary prevention is useful with these aspirin, statins, and ACE inhibitors, especially in patients with diabetes. So we'll see why that is. Diabetic patients, why are they particularly more at risk of developing this plaque rupture? Coronary intervention here is primarily for symptom relief. So far, none of the studies have shown or conclusively shown that coronary intervention is useful in stable angina. So unfortunately, many people with stable angina, all our angiogram lists and all, they are covered. They are usually full or packed with this stable coronary angina symptoms. And the patients who really need intervention, the acute coronary syndrome patients, neglected, unfortunately. It is not only in our country, it is found all over the world. Globally, this misconception is still there. So therefore, remember, for a patient with stable angina, as long as the symptoms are fine, there is no need to rush for coronary intervention. So people say, oh, I have this, I did an angiogram, it is showing this 80%, 90% of plaques, I have to do. No, there is no need to undergo intervention early. There are certain instances. If you have severe triple vessel disease, if you have a proximal left anterior descending artery, or if you have a left main disease, then it's stable angina. So those are indications for intervention. There are interventions, but that does not mean that all plaques should be stented or intervened. Right. So I talked about diabetes. Diabetes substantially increases the risk, many folds. It also increases the risk of other risk factors. So why is this diabetes like this? Now, this chronic, I'm sure all of you are aware of HbA1c, glycosylated hemoglobin, which we use to check the diabetic control over 3 months. Now, this glycosylation, it happens in the RBCs. It's same way it happens in all the cells, even the endothelial cells. So whenever you have a patient with a high HbA1c, all of their cells are also being glycolated. Now, this glycolation, it causes endothelial dysfunction and it promotes this LDL. And also, the LDL itself is made into a more pro-inflammatory molecule. Now, many of you who have been working in the emergency departments, when you see a patient with a diabetic patient coming in with an acute coronary syndrome, you check their blood sugar, almost always it's going to be high. I'm sure very rarely only you would have come across a patient, a diabetic patient with a normal blood sugar coming in with a myocardial infarction or acute coronary syndrome. That high blood sugar, it is promoting inflammation. It is promoting this angiogenesis and it is promoting the plaque to rupture. Therefore, control of diabetes is very, very important when you talk about controlling the inflammation of the plaque, as we saw before. Smoking also, it's going to increase the risk by 6 times. So yes, many people are now stopping smoking. Smoking as a risk factor generally has come down, but we have a new smoking, which is our sedentary lifestyle. So sitting is the new smoking. Whenever you get 5 minutes, we go and sit somewhere. We don't want to exert ourselves. If we have a choice of using a staircase or a lift, we will go for the lift. We don't want to walk up the stairs, even if it is just 1 floor. By doing all of this, we are increasing our atherosclerotic risk. By being active, we will reduce that risk. So it is recommended at least 30 minutes of moderate aerobic activity. So it can be anything. You can increase, you can put this activity, you don't have to spend particular time for this. You can just increase your daily activities. You can put this aerobic activity into your daily life. Right. Now, this plaque, we usually used to think that this plaque is something that is fixed. We cannot reduce the plaque. But we have found over time that there are instances where there is plaque reversal or plaque regression happening. So it is difficult to actually point to one particular reason for this plaque regression. But when you have a lot of things coming together, like good diet, increase optimal BMI, increased exercise, control of blood pressure, control of this inflammation, HSCRP, that's an important, that's another risk factor thing that we are looking at nowadays in some patients, and control of blood sugar. So when you have optimal control of all of these risk factors, as shown in this particular study, there is this plaque reversal or reduction in this cardiovascular disease risk. So all in all, it's very important that we control risk factors because, as we know, prevention is always better than treatment. Right. So when you talk about prevention, again, when does the plaque develop? So this is the important thing that I want as a take-home message. It begins at this age. It begins with the fatty streak. It begins at the ages of 10 to 20. Now, common concepts in our society is young children or young adults, our elderly people or achiammas will say, you eat, you have to eat now. You have to eat everything now. Then only you will, later on when you get disease, no, then you have to cut everything. But healthy eating, healthy lifestyle, healthy practices, they should start from childhood. From childhood, we have to prevent the ongoing risk factors, exposure. Then only we can actually prevent the disease from happening. Once a complicated plaque has developed, all calcified and fibrous plaque has developed within the coronary vessel, you can't really make that regress. By going for maximum types of lifestyle modification at the age of 50, 60 years is not going to be that useful as introducing a healthy lifestyle, healthy living from childhood. So in a way, we can think of this atherosclerotic disease as a disease of childhood. It should start from childhood. So that is my take-home message. Understanding the plaque, then you can understand coronary artery disease. When you understand coronary artery disease, the management of coronary artery disease becomes very, very easy. So thank you very much. So with this, I can end my presentation, and I think I can take questions. That's fine. Thank you.
Thank you very much, sir, for the excellent and very descriptive session. So we will move on to the Q&A segment. So we have received few questions. First one, what is the best 10-year cardiovascular risk assessment tool for Asians?
Right. So that's a bit of a difficult question to answer. We go by the accepted, the American one still, because we really don't have much studies in Asian populations. But whatever it is, the risk of the Asian population is definitely more than what you see there. So if you see, if you're according to your calculation, you're getting a 10% risk, then our patients, their risk is going to be more. That is something which we can commonly see, but that we don't have a specific tool as such for Asian populations at present.
Second question, sir, what are the early signs of coronary stenosis?
Right. So early signs. This is very difficult question to answer because there aren't any signs of early disease. We do not know that a patient is having coronary artery disease in most times, unless the stenosis reaches more than around 70%. 70% coronary artery disease stenosis. If that occurs only, there is going to be flow limitation and the patient might start developing exertional symptoms. So until that time, you do not know that you have coronary artery disease unless the plaque ruptures and you come with an acute coronary syndrome. So there are no signs. Anybody is at risk. Everybody can be at risk. Everybody is at risk actually. So therefore, proper secondary prevention, primary prevention, that is through healthy lifestyle, is important for everybody. There is no signs. There are no early signs as such. You either present with stable angina or you present with an acute coronary syndrome. For stable angina, it has to be more than 70% plaque.
What should we specifically consider about the patient who has already diagnosed as ischemic heart disease?
Right. So once a patient has already been diagnosed with ischemic heart disease, the diagnosis would have come through either two pathways. One is the patient may have been diagnosed through this chronic stable angina, chronic coronary syndrome, or the patient may have admitted with chest pain acutely and treated as an acute coronary syndrome. So these are the two ways that you can make a diagnosis of this ischemic heart disease. Now, once your patient has been diagnosed with ischemic heart disease, secondary prevention becomes very important. So when you talk about secondary prevention, we want to prevent the patient from having an acute coronary event, and we want to improve the patient's quality of life by relieving symptoms. So when you talk about secondary prevention, again, all of these lifestyle changes are going to play an important role. Plus, you can say that you are going to, we can add the medications that we said, aspirin for secondary prevention. Its role in primary prevention is now questionable, but there is a definite role for secondary prevention for aspirin. A statin, that is going to be very important. ACE inhibitors have now shown to be important because they are also reduce the inflammation and they improve the endothelial functions. So because of that, ACE inhibitors are also and now coming into the guidelines as a new way of preventing. So these are the three medications that a patient should be on, in addition to all of his lifestyle modification and lifestyle things.
How to identify LMCA occlusion in ECG?
Right. So there are criteria. If a patient comes with a significant acute coronary syndrome type this thing, you can say if there are ST elevations in AVR with widespread ST depressions in the lateral leads, then it might indicate a left main coronary artery disease. Or it might indicate a very proximal left anterior descending artery, or it might indicate severe triple vessel disease. So whatever, if you have a patient with an elevation in the ST elevation in AVR with deep ST depressions, you have to go for some form of coronary imaging, either through a conventional coronary angiogram or CT coronary angiogram, depending on the patient's condition. So only that will tell us really left main coronary artery disease. ECG, it will indicate a possibility, but we have to do the coronary angiogram to really see that.
What is the indication for thrombolysis after Q waves formed?
Okay, now after Q wave forms means quite some time has gone. So that means the myocardium has actually been infarcted. It is now dead. So if the myocardium is dead, then the patient should not have chest pain either. So if you have a patient without chest pain with Q waves in the ECG, then it's highly unlikely. A patient who has had chest pain is now pain-free. Okay, a patient who has had chest pain is now pain-free, and there are deep Q waves in the ECG. So then that risk of going ahead with thrombolysis is going to be, the risk is going to outweigh any benefit. If the patient is still having chest pain and the duration is within 12 hours, then it's always better to individually assess that patient with whoever is available and take it as at an individual thing. Because if there's still chest pain, then that means there's still some viable myocardium there, even though we are seeing Q waves. And if the time duration is within 12 hours. But if it is more than 12 hours, no pain now, Q waves, then definitely no, forget about it.
What are the screening methods of coronary artery disease and what are the preventive measures?
Right. Preventive measures, again, it is lifestyle. Your lifestyle, control of diabetes, blood sugar, control of blood cholesterol, control of hypertension. That is the prevention. Primary prevention with aspirin used to be thought of those days, but now it is controversial and it is reserved only for patients with high coronary artery risk factors and within 40 to 70 years with low risk of bleeding. So main prevention is going to be, primary prevention is going to be through control of these other risk factors. Screening itself is going to come through the history of the patient's exertional symptoms. The history is very important. Baseline ECG, that might show some things. Exercise ECG can be done if the symptoms, if there are something which suggests the patient is at increased risk of coronary artery disease, or there are some symptoms. If the patient is at a high risk and you still think there is a risk that this patient may be having coronary artery disease, then a CT coronary angiogram is being more accepted as a way of looking to see whether the coronary vessels are. Currently, if you want to do screening for a patient with a high risk of coronary artery disease, where you want to really exclude the possibility, then CT coronary angiogram will be the best imaging modality for that particular patient.
What kind of coronary vessels are not suitable for PCI?
Okay, so there are many instances where PCI cannot be done. So if the plaque is a diffuse plaque, say the entire blood vessel is covered in plaque disease, so then where are we going to go and place the stent? Palliatively, we can place the stent in a point where the most tight position is. Say a patient is having an 70 to 80% plaque disease all over, but at one point there is a 99% very critical stenosis. Then we can just palliatively put a stent there. But otherwise, it's really medical management is going to be better. If the blood vessel is too small, so the smallest stents that we have are 2.5 millimeters. So if the blood vessels are smaller than that, then you can't put a stent there. It's going to cause rupture of the blood vessel. If the anatomy is complicated, so sometimes you have complicated anatomy where you have the plaque developing at bifurcations or trifurcations and places where you don't really want to mess around with. So in those patients, we will not be going for stenting. We will prefer to go for coronary artery bypass grafting. So it depends on each individual patient, their particular presentation and their particular coronary anatomy. So,
yeah. What is the choice of treatment for reducing the recurrences of acute M1?
Yeah, so choice of treatment are those: aspirin, atorvastatin, and ACE inhibitors. Control of diabetes, control of blood sugar, control of hypertension, control of cholesterol. Exercise, eat a healthy diet. That is the prevention.
When does a patient need a CT angiogram or cardiac functional MRI scan?
Yeah, so I think I've already answered this question. So whenever there is you think the patient is having a high risk of coronary artery disease, and you want to do a screening. So those are the places where this is going to be useful.
How long should a patient be on dual antiplatelets after a myocardial infarction?
Right, okay. So the duration of dual antiplatelets is it is subject to many studies and things. So at the moment, currently, the recommendation is 1 year. So dual antiplatelets should be continued for a minimum of 1 year, following which the patient should be on single antiplatelet therapy for life. So following an acute coronary syndrome, minimum, or no, not minimum, it is the recommended at the moment is 1 year. Unless individual patients, you have the patients at high risk of bleeding, you do not really want to continue the dual antiplatelets for a longer time, then you can consider stopping it at an earlier point, depending on the patient's control of other risk factors and his clinical status. But generally, it is for 1 year. Dual antiplatelets for 1 year, following that single antiplatelet therapy for life.
How long should a patient continue aspirin following MI treated only with medical management?
Yes, aspirin is at the moment recommendation is to go lifelong. Following as secondary prevention, aspirin is lifelong. That is the current recommendation.
What is the platelet cutoff we can start antiplatelets in a patient with thrombocytopenia?
Yes. So usually we think of 100,000 as the safe point. Anything less than that, we are a bit worried. But up to 100,000, you can safely start antiplatelets.
Sir, do we use colchicine for secondary prevention of MI?
Not yet. So there are some studies and actually recommendations are coming up, but still it's not yet widely accepted.
Sir, does pre-diabetic patients need tight control of blood sugar with oral hypoglycemics?
Right. Pre-diabetes itself, we say that you do not need to give oral drugs. No. So pre-diabetes, you want to improve the patient's lifestyle, diet, exercise. So those are the things, and also definitely you have to look at the other risk factors like hypercholesterolemia, hypertension, smoking. Those things should be controlled. But pre-diabetes itself, we don't really treat with oral hypoglycemics, no. But somehow you have to achieve the best control as possible through other means.
Sir, what is the underlying mechanism of giving high dose of antiplatelet at the onset and continuing low dose?
Okay. Now, the response to antiplatelets is sort of initially is dose dependent. So what we want to do is we want to give these antiplatelet medications and we want to inhibit the platelet aggregation. Now, when you give a low dose, say we can start at a low dose at a early time when the patient presents with an acute coronary syndrome, you can start with a low dose. Okay, but the problem is the total inhibition of platelet aggregation is going to take more time to develop. So say for example, if you give a dose of 300 milligrams and you are able to inhibit the platelet aggregation by about 3 hours time, but if you give a low dose, that same inhibitory effect might be achieved only at around 10-12 hours. So over all those hours, that platelet, the thrombus is going to go bigger and bigger and bigger, and it's going to occlude the blood vessel. So because of this dose dependency and time, as a long-term prevention, it doesn't matter. There is enough time for the platelets to the platelet inhibition to occur. But acutely, we want to quickly stop that. We want to quickly cut off the power of the platelets to aggregate. So that's why we give high doses initially. Okay.
Sir, what is the action of antioxidants and omega-3?
Okay. So again, there are no proper studies. I mean, there are number of studies are there, but there are no proper randomized trials as such about these antioxidants and and this one omega-3. There are theories, but still none of the guidelines. It is not really recommended in the guidelines at present. Okay. There are theories that it may have some antioxidant effect. It may reduce the inflammation and things, but still, it is better to recommend the patient to eat fruits, vegetables, fresh vegetables, where there are more active antioxidants than to waste money on these things. So anyhow, that's based on opinion. Okay.
Sir, do we need to give aspirin 300 milligram loading dose who is already on aspirin?
Right. So if the patient has been regularly taking aspirin, patient is regularly on aspirin, then no, it is not really needed. But theoretically, yes, the platelets have now been inhibited, so therefore it's not needed. But still, there are platelets which should have escaped that aggregated this thing. So when a patient is coming with an acute coronary syndrome, that tells you that there is active platelet aggregation happening. Otherwise, the patient wouldn't have come with this acute coronary syndrome. So therefore, somehow the inhibitory effect at that time is not enough. So therefore, always we will give this loading dose. Okay. Even though theoretically it might seem that you don't need it.
Thank you very much, sir.
Okay.
If you need more clarifications or if you have more questions, please send your queries through our email displayed on your screen. So now we are going to wind up our session for today. Again, I would like to thank Dr. Rajeevan Francis on behalf of GMO and Sri for giving your valuable time and sharing your knowledge with us. Thank you very much, sir. Last but not least, I would like to thank Sri Lanka College of Internal Medicine for giving your support to arrange this session. So we are going to wind up our session today. Have a good day, everyone. We will see you on next week.
Thank you. Thank you.